Today I want to continue where we left off last time, and I was talking about coronary artery disease. So last time I talked about what's the underlying substrate, so what's happening with the myocardium with coronary artery disease and so on. And today we'll go a little bit more into the cardiac mechanics. It's like how the mechanics is changing, so how cardiac deformation is changing when there is coronary artery disease. Now, I first show you this image or the couple of images. So this is one patient that came into the emergency department with clearly chest pain and clearly some problems with the heart. And so the question is this a myocardial infarction? Is this coronary artery disease, or is this something else? And I'll just show you these images, and then later on we'll come back to that. I don't know whether we will manage today or otherwise in the next class, but what I just want you to show you already is when you look at these images, what you clearly see is like, so this hole is the left ventricle. What you see is that this apex is clearly not deforming. So you see that this apex is really not functioning. It's like bulging out even. And you see that all deformation is in this basal part, and you even see that this basal part is almost collapsing. So here you see it from a different view. So you really see that there's something wrong in this apex while the base takes it over. And then, so you would think, or potentially this looks like a massive myocardial infarction, as I also shown an example last time. But when you look at the follow-up of this patient, so you see here, 10 days later, when the patient was going home again, what you see is that actually this heart almost normalized. You still see, though, that it's reasonably thick. There is this kind of basal septal hypertrophy that we will come back to at another time. But it seems that there's still some function left in the apex. So the question is now, how can we understand it? How can we see if there's like no motion whatsoever or no contraction in this apical region? How can we try to understand this, the underlying etiology? And that's the most important. So this is where cardiac mechanics comes in, and that we can try to understand which type of deformation patterns we see there and what it actually means. Now, coming to acute coronary syndromes. So let's first start with a kind of simple model, or a kind of the simple explanation of what happens when you have an acute obstruction of a coronary artery. So that means that when you totally obstruct a coronary artery, and actually these images come from an animal model where there was a balloon inflation in the coronary artery perfusing this territory. So when you inflate this balloon, you totally occlude this coronary artery, and you know that there's no perfusion whatsoever going to the kind of perfusion territory of this coronary artery. Now, when you look at this, so what's happening, it's actually nicely shown on this M mode image. So this is the M mode of, this is actually in a peristernal view of the lateral wall with a circumflex occlusion. So what you see there is when we look with the ECG, as we said before, you always have to look with the ECG. So what you normally have is you have inward motion of the myocardium, so of the wall. So the wall moves inward in order to, of course, decrease the cavity. At the same time, you have thickening. So this is the radial thickening that I talked about. So you have, when you look at the whole heart, you have the longitudinal shortening, dragging the valve plane towards the apex. You have the circumferential shortening where the circumference is changing. And then because of conservation of volume of the myocardium, you need to have this kind of radial thickening. And that's what you nicely see here. And then you see at the end of the ejection period, you see the relaxation. So the myocardium goes outwards again, thins, and actually you have a second outward motion and slight thinning with atrial contraction. So this is the normal kind of myocardium. So inward, outward, thickening, thinning. That's it. Now, if here at this moment, we do a full occlusion of the coronary artery there, what now happens is that, of course, gradually, so that means you stop the blood flow, but of course, there's still some blood there in that area. So there's still some oxygen, some nutrition there. So, but very quickly, this is depleted. And what you start to see is that at kind of 5 or 6 beats later, what you start to see is that this notch is starting to appear. So you see now this actually a second inward motion. This is what we call post-systolic motion, because what we know, of course, is that also with regard to the ECG, but if you look at imaging also, is the aortic valve will close approximately at the peak here. So that means that everything that's happening here is post-systolic, as we say, or early diastolic, however you want to refer to. So this second bump, and you see that actually the second bump is getting so gradually worse and worse, or gradually more dominant, let's say it that way, because this images you have to see, so it's like a continuous recording from one to the other. And here you clearly see, for example, that the second peak is as dominant almost as this first peak, and there's almost no thickening here in this first, and you clearly see that there's some thickening in the second one. You can also clearly see here, what you see here, this is the mitral valve. So what you see here, the mitral valve is closed, and at this point, the mitral valve opens. So this is even some inward motion of the endocardial wall that is happening when the ventricle is already filling. Because when the mitral valve is open, you know that there's already blood coming from the atrium to the ventricle. So this is clearly post-ejection, post-systolic, or diastolic, however you want to call it. And you see that over time, you see that this remains the dominant portion. So the question is now, what's going on? Why is this happening? And can this then also tell us something about what's underlying? Now, in order to understand that, we have to go back to a couple of principles. So what really is important is that we need to try to understand the relationship between what we see in the deformation and what is related to the contractility. Because in the end, that's what you want to know. You want to know how your tissue, how your cells and so on, but mainly your tissue, how it still can contribute to the ejection, and how this deformation is then taking place with regard to the intrinsic function. So in order to understand this, of course, we need to use the regular laws of physics. And one is Hooke's law. And Hooke's law says that if we have an object, we put a force on this object will deform, and the deformation will be proportional to the elasticity. So that means that if we have, for example, a block of gelatin or kind of an elastic material, we put a certain force, we will have a certain amount of deformation. If we now take a piece of rock, for example, of granite or whatever, we use the same force, we have no deformation. So the elasticity, the stiffer the object is, the less deformation there will be for a certain force. But we know that there is this clear relationship. So we have the force that we put on. So as we could say, for example, the loading force. So it's the stress on a certain surface or the pressure on a surface, if we go already to the heart. And that is related to the elasticity and the deformation. Now, since this is like a universal law in physics, it also works for the myocardium. The only thing is that, of course, myocardium, if we take myocardium as an object, what we know is that there's force development from within this object, because it's the cells inside that is doing the force development. So it's a little bit more complicated in some ways, although the basic principle of kind of stresses equal the elasticity by the deformation remains. The only thing is that when we look at all the forces on the object, that we have to take them all into account. And so the contractile force is obviously the one that will deform the object. Now we have to keep in mind that there's also counteracting in brackets forces, and that's what we can call loading forces. And so in cardiology, they often talk about loading. It can be volume loading, pressure loading, or something like that. But this is actually predominantly the external forces in some ways. Obviously, when we look a little bit in more detail, the obvious forces that can play a role is obviously the internal cavity pressure, because if we have the myocardium, we take a piece of myocardium, the pressure is perpendicular to the endocardium, so the myocardium feels the projection of this. And obviously the pressure is generated by the whole ventricle, and not only by this piece of myocardium. So we really have to take this as an external force into account. As I also said before, it's like the geometry will be important, because the geometry will determine how, so together with the fiber orientation or the myoid orientation, let's say it that way, that will determine how the pressure perpendicular to the endocardium is actually translated or projected into the direction of the myocyte, or the longitudinal direction of the myocyte, because that's the one in which the myocyte can develop force. So this local geometry, local curvature, potentially local wall thickness regarding the law of Laplace becomes important, but we'll come back to that later on. And then last but not least, there's the neighboring segment interaction. As I told you before, we have a piece of myocardium and we want to study how this is deforming with regard to its contractility. We have to keep in mind that this is next to another piece of tissue. And when this piece of tissue that we're studying is contracting, it will try to stretch in some ways the neighboring tissue, and vice versa. This neighboring tissue will kind of do a counter force when it contracts. Normal tissue, everything is very homogeneous. There is no interaction force because these forces exactly cancel out. However, if there's abnormal tissue, and especially if there's ischemia, as I showed you last time, in ischemia, you have very, very clear and very abrupt demarcations between different perfusion territories. So you can have that one piece of tissue immediately next to another is normally perfused, while the other one is abnormally perfused. And of course, then the force development will be differential. This interaction will become quite important. Now, when we look at this relationship, and we look in general, say that we look at normal tissue and nothing is going on, there's no change in the elasticity, and also we don't induce a change in the loading, what we will see actually is that at first you can say that the deformation and contractility go together, and there's a linear relationship between the deformation and the contractile force development. Right? You can show that with the butamine and pacing and beta blocking and so on. However, that direct relationship of deformation with contractility is only valid if the elasticity is not changing. So that means you need to have normal tissue and not things like fibrosis or deposition disease or edema with water content and things like that. So as we will come back later on to. And that the loading is also not changing. So that means that when you modulate the contractility, you have to make sure that the pressure, for example, is not changing, which is reasonable within the assumption of using the butamine pacing and beta blockers, if we're talking about small infarct sizes, for example, but which of course can change dramatically in some other settings. Okay. So here's another way to look at it and already have a slightly closer view on some of these forces. So say that, for example, we're looking at a piece of myocardium, say that this is the piece of myocardium that we're looking at. So this would be, for example, in this example that I showed you, this would be the perfusion territory, for example, of the circumflex coronary artery. So we want to study the deformation and we want to infer something out the contractile force development in here, or we modulate the contractile force development by changes in perfusion. So what we need to look at is obviously the contractile force. And one of the things also that I said before is it's very important to look at the timing of contractile force development, of the active force development. Because what happens is that, of course, myocytes start to develop force at the moment that they are electrically activated. So then they start to contract in brackets, so they start to develop force. And then this force, as we said before, is being translated into pressure. The aortic valve opens, and then you have the ejection, and the ejection takes place until the aortic valve closes. So during the whole of the ejection period, the whole of systole, we have the ejection taking place. However, the force, active force that is doing the deformation of the tissue in order to do the ejection, what we see is that this actually has a differential timing. Because what we see there is that actually it obviously starts immediately at the first electrical activation of pieces of cells within the myocardium. But what we see is that it actually peaks around approximately 1/3 of the ejection period in a normal cardiac cycle. And we see then that it actually rapidly goes down. And so by the last 2/3 of the ejection phase, there's almost no contractile force development. And of course, well, there's actually two reasons for this. Is one, and we will see later on also, the fact that this is early gives us the chance to also do prolonged contraction whenever it's needed. We will see that, for example, in acute sudden pressure loading, this is a mechanism that the ventricle can use in order not to fail in really acute changes. Now, the other one is related to the contractile structure that we have, or the contractile apparatus, because what you know is that when we look at the myocytes, so the contractile elements within the myocytes is, of course, the actin myosin, and so they slide over each other. And actin myosin works or develops force by doing kind of cross-bridge cycling. So what happens is that cross bridges between the two are made, and then these are kind of buckling in order to do the deformation. Now, these cross bridges, of course, at the moment that the cross bridges between actin and myosin are connected, what happens is, of course, you get a functional stiffening of the tissue. And tissue which has cross bridges unbound or bound will have a very, very different passive kind of compliance. So what you need is, in order, after the injection, as we said before, you need to fill again, because you need to prepare for the next injection. So that means that in order for this filling to be kind of efficient, and a lot of the filling is actually elastic recoil from the previous contraction. So in order to have efficient early filling, you need to be as elastic as possible. Your tissue has to be as elastic as possible. So that means that all the cross bridges have to be broken down by the time that you start your filling. Now, the cross bridge breakdown, that takes time. And also, as you might know, that is actually the kind of mechanism within the myocytes that is actually consuming energy. So you need to actively use energy. You need to use ATP in order to unbind the cross bridges. So this relaxation of the tissue, this intrinsic relaxation, that's the one that consumes energy. But the main thing is that you just need time in order to do it. So that means that by half of systole, or even in the starting the after 1/3 of systole, you need to start breaking down your cross bridges so that at the aortic valve closure, none of them are bound anymore, and you do an efficient filling. Now, as opposed to that, obviously what we know is that the pressure buildup is, of course, different in timing. So what we see there is that the pressure is starting to increase during the isolumic contraction period, and then it will follow the aortic pressure during the time that the aortic valve is opened. And then when the aortic valve closes, you have a rapid decrease of the pressure. So the pressure is high during the ejection period and is low besides that. And also the pressure is extreme in some ways. It's like a very high force, which kind of suddenly builds up and suddenly comes down in the isolumic period. So, and besides that, so the pressure, the contractile force, so the pressure, as we said before, perpendicular to the endocardium, and then you need a projection depending on the local geometry, the contractile force, and the other one is, of course, the interaction force with the neighboring tissue, how it's connected to it. Okay, let's now go back to what happens during an acute occlusion. So as we know, as I said before, so what happens is that we get this kind of both, when you look at it, you get both or two things which are major here in some ways. So what you have is that at the one hand, you have a decrease in the systolic deformation. So you have much less thickening during the ejection period and much less inward motion in some ways also. Then you have a little bit of outward motion, and then you have the second peak of inward motion again that you can see here. And actually, when you would reperfuse, so that means that you would restore the perfusion within a short period of occlusion. So if you occlude for a minute, for example, and then you reperfuse, during that minute, what happens is that, of course, in that time period, there is no oxygen anymore. So at some point also, there will be absolutely zero contractile force there locally. And also, if you reperfuse fast enough, then of course, there's no irreversible damage. Because the cells, before the cells get irreversibly damaged, that takes a little bit longer. That's mostly like that you have to occlude for an hour or something like that before you really start to get myocyte damage. So the question is now, what is happening? Why is this occurring? Well, for that, people have been doing in the past quite interesting experiments. And also maybe just to, for your interest, if you're ever interested in trying to understand these basic physiological things, is going back into the old literature in the 70s, 80s, and beginning of 90s. There's quite a lot of literature from animal experiments in the lab, and then using for deformation analysis. Before we had image-based deformation analysis, what they were using is they were using microcrystals. So we kind of, where you kind of sew crystals on the myocardium, and these crystals can actually by ultrasound measure their distance from each other during time. And so this way you can really look at absolute deformation of tissue. That's like the gold standard in practice. Now, maybe one thing just also to remind you is, keep in mind that many of these experiments, especially the oldest one, are not necessarily in a full physiological setting. Because as I told you before also, it's like the pericardial constraint is actually very, very important in order to keep the full geometry of the heart. And if you take away the pericardial constraints, you will have geometry changes. And because of that, you will actually have deformation changes, because you change the angle of the myocytes with regards to the endocardium. So many of these experiments have been done with open pericardium, because you need to open it to put these microcrystals on top of it. And so some might not be fully physiological, but still you can learn a lot from them. And here are two very interesting experiments that help us understand why we get this post-systolic deformation. And the first one that you show here is that people started to see is like, can we in an easy model reproduce deformation and measure what the influence would be of a change in perfusion? So what would happen if you would decrease the perfusion, or if you would have prolonged decrease in perfusion, what happens with the mechanics? And this first image is from an experiment where they actually took pieces of trabeculation that they would cut out of a heart, of a fresh heart, and then they would put this in a setup where they can kind of electrically stimulate these trabeculations, and where they can put them, if you put them in water, which is oxygenated, and the trabeculation is small enough, you get perfusion. You can actually also change or control the perfusion that you get here. And they take trabeculation, or sometimes they take papillary muscles, because there, of course, the fiber orientation is relatively easy. Both in the papillary muscles and the trabeculations, you only have one type of fiber orientation, namely in the longitudinal direction. And what they saw now is that if you take one strip of papillary muscle, and if you then decrease the perfusion gradually, what happens is you decrease the contractile force, and you only decrease the deformation. You do never get post-systolic deformation. You just get a gradual decrease of the amount of deformation. However, when they would take two pieces of myocardium, so two trabeculae, and you put them in series, and one of them you make hypoxic and the other one you keep normal, then you start to see what they measure here. That means that if we have hypoxia, you get a gradual decrease over time of the systolic deformation, and you start to get post-systolic deformation. So you can only get post-systolic deformation if you have both normally contracting and abnormally contracting myocardium, which are connected to each other. So this is where I said this interaction is extremely important, because otherwise you do not get the phenomena that you really see in practice. So this means interaction is important. Now, the second experiment is looking a little bit more at the timing. And what you see now is here in red, you see the pressure, and you see two areas. The solid is normal myocardium, the dashed is hypoperfused myocardium. And you see exactly the same. So after a while, so after kind of a limited amount of beats after total occlusion, what you see is you have actually first a little bit of stretching always, then decreased systolic deformation and post-systolic deformation. But what's interesting is that that you see that the relation of this post-systolic deformation is actually with regard to the pressure. So you see that really it's the pressure that divides, or the pressure change that divides the two. So it's really whenever the pressure drops, so which means the end of the ejection, then the phenomena are happening. So from these experiments, you know that we have to look at interaction of segments, and we have to look at what's the influence of a rapidly changing pressure? How does the change in pressure influence the deformation? And so then after, I mean, it actually took us a while in order to understand it. And actually also for the engineers, interestingly enough, the engineers came up with this kind of explanation, especially after the cardiologist would say like, okay, we have this second contraction. So that means that we can only have a contraction in rip motion if there is active force developed. So that means that they say like, yeah, there has to be somehow a second activation or a second contraction or whatever, but we need to have an active component in order to get this thickening. While the engineers, they would say like, no, not necessarily. You just have to look at the whole mechanics. And so in the end, and I'll show you also some simulations later on, we came up with this explanation, and this is shown in this cartoon. So the easiest to understand it is to follow two pieces of myocardium, which are connected to each other during the cardiac cycle, where one piece of myocardium is normal and normally perfused, and the other piece of myocardium would be hypoperfused. So we would decrease the contractile force development in the piece next to it. So, of course, at the end of the diastole, what you have is both are relaxed, both are thin. So then we get electrical activation. What happens with electrical activation is that, of course, the normal myocardium is starting to thicken. You can actually make the same reasoning, of course, in the longitudinal direction with shortening, but let's do thickening because that's shown here in this cartoon. So normal myocardium is starting to thicken, and during this thickening, it has developed a force together with the rest of the myocardium, of course, in order to build up the pressure. So that means that this is thickening against the high pressure. Now, the abnormal myocardium, if the contractile force development is less because of hyperperfusion, or we can see later on because of other reasons, what happens now is, of course, because of the force development is less, but the pressure remains, of course, the same. The difference between pressure and force development is different, and this piece cannot thicken as much as the normal piece. So by the end of the ejection phase, we are in a situation where we have thick normal myocardium and less thick abnormal myocardium, which is in some ways held back by the pressure. The pressure is an enormous force that makes that the abnormal myocardium cannot thicken any further. Now, what you have to keep in mind is, of course, that, as I said before, these pieces of tissue are connected to each other, and there's really adjacent to each other. That means that there's an elastic interaction, meaning that they're connected to each other, so that the thicker myocardium is, of course, elastically trying to pull up the thin myocardium, and the thin myocardium is trying to pull down the thick myocardium. However, this elastic interaction force is much, much, much smaller as compared to the pressure. So that means that at the end of the ejection phase, when the pressure is still high, we have this stable situation: thick myocardium, thinner, abnormal myocardium, pressure and interaction force. Now, of course, the moment that the aortic valve closes, what happens now is, of course, you start to go into the relaxation phase. The pressure is suddenly out of the equation because the pressure drops rapidly. Of course, the tissue will not change so rapidly in its dimensions. But what is happening is, of course, that the normal myocardium normally is starting to thin slowly, as it should do during the filling phase. So you start to see that the thick myocardium is thinning, but it's still thicker than the thin myocardium. And now the only interaction force that is available, of course, is this elastic interaction. And because of this force, now that the pressure is taken away, and this is the only force available, what happens now is that actually the thick myocardium is starting to pull up the thin myocardium, and vice versa. The thin myocardium will start to pull down the thick myocardium, up to the point that they have the same thickness, and then they will thin further together at the same time. So that's shown here. So you see both the same at end diastole, at end systole or end ejection. We have this phase, or this situation with thick normal myocardium, thin abnormal myocardium, pressure holding this in a stable situation, but having interaction forces. When the pressure drops away, we only have the interaction forces, and you start to get thinning up to the point that they have the same thickness, and then they go down together. If we would measure the thickness, or if we would measure the strain, what you see is that during the ejection, you have the thickening of the normal myocardium, and then you have the monophasic thinning of the normal myocardium. potentially with atrial contraction later on. So you will have, because of the fact that there's a different balance between pressure and contractility, with decreased contractility, you will have less deformation during ejection in abnormal tissue. And at the moment that the pressure drops, you start to get the interaction where the thin myocardium is being pulled up by the thick myocardium up to the point where they have the same thickness, and then both of them will go together. And obviously the result of this is that you locally see in this abnormal myocardium, you see post-systolic thickening. So the post-systolic thickening is nothing else but the passive mechanical interaction between neighboring tissues which had a differential systolic deformation. So what is also important is that post-systolic thickening will happen when you have decreased contractility. So with coronary artery disease or ischemia, so decrease in perfusion, you will get post-systolic deformation. But since this is because of an interaction between differential systolic deformation thickening, what you will see is that in any situation where we have this differential deformation during the ejection phase, we will get post-systolic thickening. And that can be because of a decreased force development due to abnormal perfusion. It might be that there's some defects that will locally change contractile force development or things like that, but it can also be because, of course, of differential activation. If you have a piece of tissue which is kind of activated later with regard to another one or to a neighboring one, of course, you might have inhomogeneous systolic deformation, which then would result in post-systolic deformation. And when we talk about, for example, a bundle branch block or pacing, we will see that that will be the case. But it can also be that you would have differential loading. So that means that if the pressure, or at least the stress induced on the myocytes because of the pressure, locally will become inhomogeneous, so that the myocyte stress will be higher in some regions. Of course, again, you will have this imbalance between the pressure and the contractile force development, and we might get this. And we will see later on that, for example, in hypertension, aortic stenosis, or something like that, you will also get post-systolic thickening. And last but not least is, of course, if you would have changes in the local elasticity, so say that you would have local fibrosis in one segment, of course, if you have a change in a kind of a stiffening of the tissue and you have the same contractile force development, it might be more difficult to do the systolic deformation, and you might get again an imbalance and look at and then get the post-systolic deformation. So that means that post-systolic deformation is extremely sensitive to detect regional differences in deformation, but it's not specific to one etiology or the other. And you have to figure it out. And we will see that depending on how much it is, and especially where it is, and of course the other boundary conditions, we can try to understand this. And here you see this in some kind of, this is actually based on simulation. So this is like a simple mechanical simulation where you have pieces of tissue connected to each other and you differentially change either the amount of force development or the timing of the force development. And what you will see then is that if we have a gradual decrease of force development in the segment that we are looking at, what you get, as we said before, is you get decreased systolic deformation and more post-systolic deformation. And even if you have zero force development, what you actually get is you get stretching first, and then you get a little bit of systolic deformation with post-systolic deformation. Now, if we have a prolonged force development for whatever reason, what we start to see there also is that because of this prolonged force development, what can happen is that indeed we can also have this post-systolic deformation because of that. And then if we have a change in stiffening, so say that this would be this is actually an acute occlusion of normal elastic myocardium, you see the post-systolic. However, if this myocardium becomes stiffer and stiffer and stiffer, what you see is that obviously there's no deformation, but you see that also post-systolic deformation will disappear if the tissue becomes so stiff that, of course, the elastic interaction forces are not big enough anymore in order to deform it. Because as we said before, Hooke's law says the deformation will be kind of related to the force that we have and the stiffness of the tissue. So this is what we need to look at always. As I said before, we need to look at tissue properties, and we need to look at the force development. And as we said before, force development, both contractile, but also looking at the loading, for example. So coming back then to a couple of kind of acute situations where we have sudden changes in the perfusion and thus the force development. So obviously, when we have an acute occlusion of the coronary artery, there's obviously zero perfusion. That means that after a couple of heartbeats, there's really zero active force development. And also in the acute phase, so if you do this, there's actually no change, obviously, in the elasticity of the tissue. So the tissue is not changing. There is no fibrosis, of course, acutely. There's no kind of edema acutely. So the only thing that happens is that the force development changes. And then, as I showed you before, this is what you get. First, stretching. And the stretching is, of course, because the pressure is being built up and then pushes out the tissue. What you then have is here now, although, as I said before, the interaction forces are not very big, but of course, by the end, if you have a huge difference in the thing, there is a little bit of elastic interaction. But the main thing is that you get this post-systolic deformation when the pressure is dropped, and then later on at diastole, they come together again. Now, there's also a couple of interesting things when you look at the amount of this post-systolic deformation that you have. And this amount actually, as I said before, this actually depends also on the loading conditions. And here is an interesting experiment where they actually did different types of decrease in perfusion. And at the same time, they would also change the loading. So what you do is you can increase the afterload, for example, by a constriction of the aorta or something like that. And then you see these different conditions, and it tells us something already that we go in more detail when we talk about pressure loading, but it's interesting to already go in a little bit of detail. So here you see that you have normal myocardium at baseline, and you see that there's virtually no post-systolic deformation, but there actually is a little bit. And especially, we will see later, especially in the flattest areas of the myocardium, which is predominantly the basal septum in normal hearts, we see that there is a little bit. But normally, there's very, very little post-systolic deformation, and everything is systolic deformation. Now, if we acutely change the loading, what we see is that acutely, actually, we increase the post-systolic deformation. And this is what I told you, with acute loading, and especially since the heart knows fear, and we come back to that in another session, we will see that actually there's inhomogeneities in how the pressure is translated into wall stress on the myocytes. And we see that we actually get an increase in post-systolic deformation, and we get a little bit of bulging even, and this will be in the same regions mostly. If we have a critical occlusion, so that means that we occlude the coronary artery, but in such a way that we still have normal perfusion at baseline. So that means that there will be no exercise capacity anymore, but it's still kind of just enough perfusion. And we'll see that that doesn't change at all. So we really need to have a decrease in perfusion in order to get a change. What we see there, although, is like while the normal myocardium, so without changes in loading, we see that it's exactly the same. If we load, we actually see that there's a little bit less deformation and a bit more post-systolic deformation. So loading can actually bring the myocardium over the critical point of the exact amount of perfusion that you would have available. Now, if you start to induce ischemia and more ischemia, what you see is you get, as we said before, we get a little bit of bulging, decrease in systolic deformation, post-systolic deformation that is exaggerated if we increase the loading. And it's even so that if we have quite a critical stenosis, what you see there is that actually because of loading, it could be that we only have bulging and post-systolic and no contraction or no systolic component whatsoever anymore. This is important if you want to understand what happens with patients that have both pressure loading, either it being hypertension or aortic stenosis, and on top of that will develop coronary artery disease. This is something which is typical, for example, is like elderly patients that have critical aortic stenosis and then at the same time are developing coronary artery disease. What you see is that, of course, that the effect of the coronary artery disease is exaggerated by the critical stenosis, because the balance between the pressure and the force development is, of course, the thing that is relevant. Not the force development itself, but always this pressure between the contractile forces and the loading forces, because it's this difference that is related to the deformation and then the ejection performance. And what you see also is when you reperfuse again, of course, it normalizes more or less. Although what you see is that you get, this is a phenomena that we will call stunning, and we'll come back to that later on, that if you have a certain period of time that you had abnormal perfusion, and then you totally restore the perfusion, what happens that it can take a while, and in reality, in patients that, for example, had months of problems with low perfusion, if you reperfuse them, it can take weeks up to months before the myocardium fully recovers. And we'll come back to that later on, why this is. But the main thing is that we said that is pressure dependent, and actually you will see that it's also, or that at least part of it is volume depending. And the volume is actually not so much related to the post-systolic, although if you have a lot of volume loading, you also get more post-systolic. But what you see is that the bulging part is actually more related to the volume, which of course you can imagine, because if you add volume, what you do is you start to stretch tissue. And if this tissue is already stretched, it cannot stretch much more. Because also, we might come back to that later on, the myocardium is actually hyperelastic, which means that the more you stretch, the more you make it bigger, the more stiff it becomes. Plus, you normally have also the pericardial constraint, which also makes that you cannot blow up the ventricle a lot. Okay, so as I said before, and this is now for measurements, it's just to show you the relationship or the difference between acute loading or acute occlusion versus like a slow graded occlusion or a decrease in perfusion. So as we said before, acute occlusion will give you bulging, less systolic, big post-systolic, and almost nothing else. You reperfuse, it normalizes. If you, however, gradually decrease the flow, so once you are at the critical flow and you decrease so that it becomes ischemic indeed, so that means that there's not enough oxygen for full normal functioning, what you see is that together with the decrease in perfusion, what you see is that the systolic deformation gradually decrease and you have this post-systolic deformation. And that's actually also shown here in another kind of animal experience. Here you nicely see how blood flow and deformation is actually related. So this is the systolic thickening, this is the blood flow. And actually what they did is also they measured it differentially, transmurally, so over the whole thickness of the wall, and partially subendocardially and subepicardially. So they did that actually by, again, with these, what I said, these sonomicrometry transducers, where they actually implanted a transducer really in the mid of the myocardium, which is of course rather invasive, but it still tells you something that's going on. And what you see there is, again, that there is this kind of really linear decrease of overall deformation with decrease in blood flow. And that's predominantly in the subendocardium. So in the subendocardium, if you decrease the perfusion, it's the subendocardium that goes down predominantly. And what you also see is that in the subepicardium, what you will see is that there it's kind of constant much longer, and then it starts to decrease. So there is actually differential thickening in both. And that's what you always also have to keep in mind. And so you see here again, you get the decreased systolic deformation and you get the typical post-systolic deformation always when you get to the graded perfusion. Okay, I think that's enough for today. So just to summarize, so what you get is you have very typical mechanical changes if you change the balance between the force development and the pressure. And that's always crucial. You can only understand certain deformation profiles when you take the balance into account between We have the deformation, we observe the deformation, or the other way around if you want to generate the deformation. So the deformation is related to the forces, all the forces that act upon a piece of tissue, and it's related to the elasticity. Changes in elasticity will change how the contractile forces are translated into myocardial deformation. And then within the forces, changing loading forces are as important as the changes in contractility. And changes in loading forces are predominantly pressure, obviously. So pressure modulation will modulate deformation, even if contractility change stays the same. And segment interaction would also do that. And especially when we are in the situation of differential changes between different segments, it is interaction, the kind of elastic interaction, because of the fact that these tissues or these pieces of tissue are connected to each other within the ventricle, and even in a bigger setting within the whole heart, within the pericardial constraint. So that you have to keep in mind in order to both understand it, or if you want, as an engineer, want to simulate it. All of these things are as important. Any questions?
I have a question. Can you, on one of the slides, you had this prolonged force development. Can you say something more about this?
Yeah, well, the prolonged force development would be potentially when you have differential loading, although you don't see it that much, but this is actually predominantly to look at, for example, delayed activation. Actually, this simulation was done at the beginning of resynchronization therapy, where we still didn't understand what we later know is about the septal flash, which we come later on. And at that moment, it was thought that the late activated regions would just contract longer. Now we know that there's also something happening in the early, but still with the contraction of longer, it is still the same. It's still interesting. What we see there is we see post-systolic. But one of the things that you also see is like when you start to compare them, when you have prolonged contraction, you have much less this kind of little bulge or little decrease fully at the end of systole. Yeah? So you really see much more this continuously prolonged deformation, which just continues further than aortic valve closure. And this is what you see, for example, in the setting of left bundle branch block or pacing. You will see that in the remote regions. So if you look at the basolateral wall in the setting of left bundle branch block, we see that the deformation even continues after aortic valve closure. So it is effectively post-systolic, post-ejection, and not contributing necessarily to the ejection then. And the main thing is also that it just gradually goes from systole into post-systole without this kind of little dip there. Or you see it also, for example, when you look at right bundle branch block, it's even more pronounced there. If you look at for example, a repair tetralogy of Fallow, you see that clearly that you have really linearly prolonged contraction, which actually can continue after aortic valve closure. And that is because of either prolonged force development, but in reality, it's much more shifted force development. So in reality, what will happen is that this force development is not just prolonged, but just the onset is later and everything is shifted. Mm-hmm. Prolongation you can have, as I said, when you would have, for example, pressure loading, you would have that. But to have this real prolongation in a regional setting, I'm not sure whether that is possible unless you have differential activation. That I don't think so.
So how would in hypertension you have, for example, in loading, how would you have prolonged activation in a regional area and not just get less contraction of this segment? Why would it be prolonged?
Well, you have prolonged contraction and not activation. So in the setting of hypertension, activation is not changing. But what happens is that the region where you have more loading, what happens is that, as I said before, it could be that regionally you would have this kind of delayed relaxation at the contractile material. So if you would have regional increased loading, we'll come back to that in another session. So then what you would have is that the active relaxation in that region might be a little bit later. Now, honestly, I think in hypertension, what you will mainly have is that this might be overall. I think the whole myocardium will start to do that, and the post-systolic that you will see in hypertension will mainly be because of regional differences in loading rather than in prolonged contraction or delayed active relaxation. But it might be that the two play a role. So in some ways, you're right there.
I'm just kind of not completely sure I get why relaxation would be delayed in a pathophysiological sense, just like on the molecular level. Why would it happen?
We can come back to that later on, but the reason is actually when you look at the mechanism, it's like your cross-bridge cycling is actually related to the length, the instantaneous length. So that means if you have slower shortening and lower strain rate, what happens is that you actually actively contract longer. So the trigger internally, the molecular trigger to start the relaxation has to do with the length. You have this force length relationship with the myocardium.
Okay.
Any other questions?
Is it then the same when you start breaking the cross bridges, or it is when you break, then it's independent of the length? Because
no, this is what I'm saying. This relaxation, the relaxation is effectively the breakdown of the cross bridges. So that's what we call intrinsic tissue relaxation.
Yeah, no, I mean in regard to the previous question. So if it would be dependent on the length of the contraction as well.
Yes, obviously. And the level of contraction at a certain moment within the cycle will depend on the loading or at the imbalance or the balance between the contractile force and the loading.
Yeah, thank you. And another thing I was seeing in the slides, of course, is all these studies were mainly focusing on radial strain because it was how you could acquire the data. How does it impact the longitudinal strain? It's
exactly the same. So it's exactly the same. So again, you can make the same reasoning with longitudinal, and it's mainly this elastic interaction which makes the difference. So all these things you see on the longitudinal as well as on the radial. So
okay. And finally, when will we have maps of the myocardial deformation, like 3D, instead of having these 18 regions? Because I guess then you can...
Full 3D, yeah, I mean, the companies are working on it. The problem is that currently ultrasound technology is not fast enough yet to have the ideal temporal and spatial resolution in 3D as we currently have in 2D. So, and the other thing is also the fact that we use these standardized regions in echocardiography is for reporting purposes. But it's also related to the resolution because our imaging technology in general has a resolution in the order of, in the best cases, maybe 0.5 centimeter, a couple of millimeters. I don't think we can do a lot better. And the other thing which you also have to keep in mind that within cardiology, you always have to look at things which are clinically relevant. So if you would have an abnormal region which is less than, for example, 1 cubic centimeter in the myocardium, this is absolutely not going to have any clinical relevance and is likely going to be treated neither. So unless it causes arrhythmias or something like that, but that's something different. But from the mechanical point of view, if we have a resolution of 1 centimeter roughly, that would actually be fine. So, and this is close to what we can. Better is potentially better, but okay, we just can't do it currently technically.
No, of course, I totally agree with you. I was more asking in the direction if the actual region that is not deforming is between two of these sections that are pre-established, and then you have somehow non-normal strain and strain rates in both of the sequences, whereas the region is probably half of each section.
No, that's the other thing is if you would, the way it reports is if you would take the averages, then of course many of these things you don't see, then you get blurring. So that's why also when we talk about practical applications, very often, and actually also for research, but again, there's also again a difference in when you do the research and how you report it in a paper, because in a paper you need to make numbers in some ways. But what is also the case is in that many of the applications, besides the big segments, you can actually also either go over it with your cursor and look at the spatial change in the curves, or kind of measure it in smaller regions.
Okay.
But as I said, all of this is always on the balance, or a balance between image resolution, the regularization that you need in order to do a reasonable strain assessment, and then the way that it's feasible and convenient to report it afterwards in either an individual report for a patient or in a study for a paper.
Yeah. Thank you.
Any other questions? Otherwise,
I just have another
go ahead,
one.
Go ahead.
Yeah.
Go
No,
ahead.
I'm just thinking like when we do speckle tracking strain and you go with the cursor follow, for example, the septum, and we have post-systolic in the basal septum, it means that like the post-systolic, the neighboring region will eventually fuse and then shorten together with the region with the post-systolic, right? And that we should be able to see. I never looked at this specifically, but I mean,
yes,
that's
you see that there's a gradual change. Now, there's a couple of things here that are relevant in some ways. So we know from the anatomy histology that actually the perfusion region can very abruptly change. So you really over a millimeter, for example, you might go from one territory or from non-perfused into perfused. Mm-hmm. Now, the mechanical consequences, so obviously that means that your force development locally would also be very abruptly. The other thing is that, of course, when we look at the deformation, then we get already, because of the elastic interactions locally, this is being spread out a little bit. Mm-hmm. So the first thing that spreads it is the elasticity of the tissue and the elastic interaction. That means that we don't see a really abrupt change. And then secondly, of course, as I said before, our imaging tools, both the imaging and especially the strain measurement, again, smooths out. So it's this combination. So we have kind of smoothing from the mechanics point of view of the tissue mechanics, but the elasticity of the tissue being connected. And then secondly, we have another smoothing because of the way that we measure it. And so you will see that you gradually go from post-systolic into systolic with a change where you will see that systolic will increase while post-systolic will decrease.
Okay, yeah.
Any other question? Okay, then again, thank you very much for being here and see you probably next week.